Good evening, it's a pleasure for me to be here. It's not so simple to tell the story of the prosthesis, but I can say that the first generation of prosthesis was in metal, and it was not so comfortable for the joint replacement. So the second generation of prosthesis were made in silastic, and that we see the first silastic prosthesis was the Swanson, and it was a linear silicone prosthesis with grommets in titanium, still used today in some hospitals. But according to the international literature, because of the significant piston effect, there was, after the implantation, the bone sclerosis, which was responsible for implant fracture, so the subluxation of the joint. For this reason, the previous prosthesis was substituted by the Sutter in 1987, called Avanta. Two characteristics are different before, in confront of the previous prosthesis. There is no medal in the shape of the prosthesis, and there is a more palmar center of rotation. The pivot is more, and another for the PIP joint. The reason is that in the MP prosthesis there is a deficit extension of 30 degrees, and in PIP prosthesis there is a deficit of 15 degrees of extension. And this is because the hand, without activity, has this kind of position. So if we take a look at the mean range of motion, we can see that for the MP joint with previous prosthesis, the range of motion was 60, and for the PIP, 75. But with this kind of prosthesis, with Neuflex, the angle of flexion is 90. Another important element is that the pivot is more palmar, like the Avanta, and this is important because there is the minor stress during the flexion, that is the normal condition of the hand during the activity. The instruments are important to implant this kind of prosthesis, and it's important to a training course that I had in Luxembourg. The indication for the implant are the pseudoarthrosis after the trauma, the osteoarthrosis, the rheumatoid arthritis, so condition in which there is the deformity, axial deviation, in which there are no results after drug therapy for the pain, and in which there is the loss of digital function, so a worse quality of life. But the innovations are not only on the shape or on the material of prosthesis, even the innovation in surgical procedure, because we introduced the application of lateral ligaments, the volar plate reattach, and the new skin incisions. The old incision for MP joint was on the dorsum of the joint, but the new incision is a Y-shaped incision, and this has some advantages. For example, with one incision we can expose two joints contemporarily. There are no lymphatic or vein injuries with this incision, and no scar on the dorsum of the joint, so the mobilization is early. For the PIP joint is the same. The old dorsal incision is that still used. The new lateral incision permit no incision on the extensor tendon, so an early mobilization. The disadvantage is that there is a technique more difficult than the other, and sometimes there is a ulnar or radial deviation, so ligamentoplasty probably is necessary on the other side. Take a look at the operative technique. The first time is the intermetacarpophalangeal, is the picture of the stability of the volar plate under the stress with a pen, and with the end. Another case in a woman, and this is the result. In this case, the picture is important because I can show the difference between the PIP joint and the DIP joint. In DIP joint, it's not possible to put prosthesis because there are no results. So we have to realize the arthrodesis. Physical therapy is so important for the DIP joint. It's too important to obtain result. The collaboration between the surgeon, physiotherapist, and patient, the continuous